A very warm good evening to everybody, and welcome to the Wincars Interventional Meeting. This is the special edition of our Wincars Interventional Meeting, Wincars at the ESC 2025. So this time at ESC, Wincars has been represented by a special group of very dynamic, brilliant minds, Dr. Asha Mahilmaran, Dr. Cicely Magella, Dr. Prachi Sharma, and our senior patron, Dr. Anita Saxena. Unfortunately, Dr. Anita is traveling today and will not be able to make it. She will be landing in India tomorrow. But we have three of our amazing ladies joining us today at the Wincars ESC special. For today's meeting, our chairpersons for the evening are Dr. Sujata from Vizag, Dr. Zakia Khan from Fortis Hospital, Kanyan, and Dr. Priya Palimkar from Pune. None of these ladies need any introduction. They are well known to all of you, senior intervention cardiologists, all of them. We also have an amazing expert panel joining us. We have Dr. Madhumanti Pancha from Calcutta. We have Dr. Veena Nanjappa from Mysore, and we have Dr. Priya. So without any further delay, we will start with the presentation with Dr. Magella has made. Her first topic is comparative analysis of young acute coronary syndrome in pre and post COVID pandemic. Over to you, Dr. Magella.
Thank you, ma'am. Thank you for the opportunity. I hope able to see the screen, ma'am.
Yes, we can see your screen. Please go to slideshow.
Yes, ma'am. 1 second.
I think you have to click on enable editing. Then you will be able to go to slideshow. On the top.
Yes, ma'am, but I'm not able to do so. 1 second.
On the top of your presentation, there is one enable editing.
Ma'am, please resend and I'll request you for the remote access then. Please reshare the PPT.
Yeah, sure, ma'am. 1 second. Able to see it, ma'am?
Yes, we can see it.
Okay, ma'am. So comparative analysis of 1 second, I'll put it in the PowerPoint slide. So comparative analysis of young acute coronary syndrome in the pre and post-COVID pandemic.
Ma'am, you can click on enable editing. That is on top of the bar.
Is it okay? Yeah, now it's okay, ma'am.
Yeah.
Yes, now it is in full. Yes, please go ahead.
So introduction, the rising incidence of ACS in young patients has garnered significant attention because of the clinical implications that come with incorrect or delayed diagnosis and treatment. There are several pathological causes of ACS in this population which could be categorized as atheromatous, non-atheromatous, thromboembolic manifestations. There is an increasing trend of young patients presenting with ACS, especially in the recent years. The COVID pandemic has also contributed to the young ACS. This article focuses on the practical concerns related to gender differences and the incidence of young ACS in the pre and post-COVID pandemic. The aims and objectives were to study the clinical and angiographic profile of young ACS patients in the pre and post-COVID pandemic period. So the methodology, it's an observational study conducted at a tertiary care hospital in South India between January 2018 and December 2023. All the young patients between 18 to 45 years admitted with acute coronary syndrome were included and were diagnosed by history, clinical evaluation, serial ECGs, biomarkers, echocardiography, and all the ACS patients were subjected to coronary angiography with consent. So the results, the yearly database from January 2018 to December 2023 are as follows. About a total of 10,842 patients in the last 6 years, among which 2,457 patients were young ACS patients, which constituted 22.66% patients. Among that, the males were 2,457 and 600 were female, which constituted 24.4%. The incidents on yearly basis were recorded as in 2018, the young age total angiogram done was 1,657, out of which 315 were young ACS patients. In 2018, one second, just minimize this. In 2019, among the angiography done, 380 were young, and in 2020, total angiogram done were 806. There were COVID pandemic, the angiograms had come down, among which 202 were young. In 2021, the total number of ACS angiogram done was 1,605, out of which one second. Out of which in 2021, the total number of angiogram done was 1,605, out of which 480 were young. In 2022, total angiogram done was 2,474, out of which 564 were young. And in 2023, total angiogram done is 2,668, out of which 516 were young. The angiographic data of the young ACS in post-COVID was single vessel disease was 47.7%, double vessel disease was 30.2%, and triple vessel disease was 12.8%. And we are able to see the young yearly data of incidence of the young ACS patients. The total number of general ACS is also increasing, as well as the rising incidence of both male and females continue to increase, including the young ACS. We are able to see a gradual increase, and in 2023, young ACS represents almost 516 patients, and in 2022, 564 patients. And we are able to see that even in young females in 2022 and 2023, almost 180 young females, and in 2023, it is 168 young females, less than 45 years without much comorbidities. So we have analyzed once again the percentage of young ACS, which is we are able to see there is an increasing trend, but the maximum in 2021, and also it continues to rise, and we are able to see that the gender differences in 2018, it was 72 were females, 22.8%. In 2019, among the young ACS, 86 were females, which is 22.6%. In 2020, generally, the young ACS was minimized. The total number of angiograms done was low, and the females constituted only 10.8%. And in 2021, it was 15%, but in 22, we are able to see the increasing surge of around 31.9% of females. And once again, in 2023, it is 32.5%. It is an ongoing study, but still we have presented only until 2023 with all the data in hands. So the distribution of STEMI, NSTEMI, and unstable angina, the STEMI incidence was 40.9% in young ACS, NSTEMI was 25.9%, and unstable angina was 29.54%. This is the distribution-wise. And angiographic data of the young ACS, single vessel disease constituted in 2023, once again, it was 47.7%, double vessel disease 29.9%, triple vessel disease 13%, and LMCA was 9%. The data we are able to show. And now categorizing between 2018 to 2020, the pre-COVID pandemic, young MI constituted 897. Among that, male and women constituted together 36.6%. and young MI women alone constituted 180, that is 30%. But when compared to post-COVID 2021 to 2023, the total number of young MI is 1,560, which constituted 63.5%. Among them, the young women constituted 420, that is constituting almost 70%. So, once again, we are coming to the total number, that is the total number of females are 600 and the total number of men are 2,457, which one the p-value is quite significant. The statistical analysis that both among male and female when compared to the total population as well as females in particular, we are able to see there is an increasing trend. So after the COVID pandemic, the total incidence of ACS has increased drastically. Of course, the total number of ACS has also increased, especially when compared young individuals. Also, the incidence is increasing, and young women also there is an increasing trend. So thrombus burden is high in the post-COVID patients. The postulation that COVID tends to mitigate the protective estrogenic effects in young females has to be further validated. This is just an observational study, but we have to deeply dive into the etiopathogenesis of young ACS that we are not at 100%. We are not sure what is the etiology, why there are so many young individuals presenting with the ACS even without comorbidities in the post-COVID pandemic. In addition, the research should focus on developing risk stratification models for young patients so as to prevent and treat them early, so as to reduce the overall incidence and mortality of ACS in the end. Thank you, ma'am. Thank you. This is just an observational study. I think we need to deep dive into the etiopathogenesis, and more etiology has to be taken into consideration.
Thank you, Dr. Majella. That was an amazing observational study, very interesting. And I think all of us have also experienced the same in our practice, that post-COVID, there was an increase in the incidence of young MIs and thrombotic episodes, which occurred in all of these patients. I'm sure there are going to be a lot of questions, and also questions about, do you feel that there was also a lot of question about the fact that was the vaccine in any way also related to the increase in the young MI, and COVID per se was a prothrombotic virus. So we did see thrombosis in a lot of other places also, not just the heart. But I'm sure there are going to be a lot of comments and a lot of questions. And I can see that Dr. Vijayalakshmi has also raised her hand. So Dr. Vijayalakshmi and the chairpersons and the panelists, please, the house is open for questions to Dr. Majella.
Thank you so much, Sarita. Majella, it was a very beautiful presentation and very nicely done. My question is, have you found out the etiology? In the next time, this could be a pilot study. You do a methodical study. How many of them had increased fat content? And today it has been shown that because of the sedentary habit in that period, lockdown period, lots of fat deposition is there. Because the study done by histopathology autopsy by Dr. Vaideshwar from KEM Hospital, Mumbai, he has shown that in autopsy, he has not found that corona causing the coronary artery disease or anything. But we have to find, he found that there was a fat deposition was much more after the corona infection. So please keep that also in mind when you are doing the further studies. Thank you.
Sure.
Very good and good work done. Because ICMR studies, all the four have reported that there is no correlation between corona and the coronary artery disease. So you have to find out the cause. And also, get the what to say, like the scarring post MI, corona, post myocarditis scarring. And that is increased by 20%, and that also has to be kept in mind.
Yes, ma'am, definitely. In the German study, where they conducted autopsy in almost 100 patients, post German, those were not those who had a COVID infection, those were carrier, everything that conducted the study, and finally among 100 patients they were able to find that myocarditis is present in almost 70%. They have
Oh,
so that was the German study which first got published after the COVID pandemic, which
yeah.
showed that either in one way or the other, there is an inflammatory process going on in the myocardium. But what they showed there is 70% involvement of the cardiac myocarditis in a milder way or a severe form or
Yeah.
whatever. And they've proven it by that German study. That was quite alarming, ma'am. That only
But
provoked me.
what I quoted Dr. Vaideshwar, is from KM Indian study. And in
Okay, ma'am.
India, we found that myocarditis was more among the children and the young. And
Yes,
that
ma'am.
is the
Yes, ma'am.
reason, you have to look for the scarring, and that also could be part of the process. And also the fat deposition. And he found that the fat deposition was much more in the recent time. And I think the body mass index and everything has to be calculated. Thank you very much.
Thank you, ma'am.
Madhila, Dr. Zakia Khan here.
Yes,
Yeah.
ma'am.
Can you hear me?
Yes, ma'am. Yes,
So,
ma'am.
excellent study. Although we all know that COVID belongs to one of those prothrombotic virus, like
Yes, ma'am.
flu virus. This is also a prothrombotic virus. Plus, it also causes endothelial, erosion. That's why
Yes,
you see
ma'am. Yes.
strokes. That's why you see mesenteric artery thrombosis.
Yes,
So
ma'am.
COVID is known to cause thrombosis, and I mean, we didn't do a study like you, but we were the only hospital in our area who were not admitting COVID patients, but we were doing regular work, regular cardiac work. So we had real high number of 28-year-old, 22-year-old, all coming with MIs.
Yes,
So
ma'am.
there's no doubt that COVID is a thrombotic virus. I don't know about how many of you are getting a feeling now that you have my number of seeing coronary ectasia has suddenly gone up.
Yes, ma'am. That is my next
That is a
presentation,
very
ma'am.
nice
I don't know.
I have
comment.
Yeah,
That is her next topic.
that is my
yeah,
next topic, ma'am.
yeah,
That was well appreciated in the ESE because I've been
yeah,
observing this for quite a long time, but I wanted to put it into paper almost by 2022 itself. But I didn't have the time enough to document it. But then it was
yeah.
published in 2023, the first paper that COVID can cause coronary artery ectasias in a small number of subset, which was first published in 2023. Then I thought I've been thinking it and I couldn't document it.
Yeah,
Then I
yeah.
started collecting the entire data. And this is one of the largest studies, ma'am, in coronary artery ectasia, pre and post, and it was well appreciated by the ESC. And that is why they gave this, they asked for the 1 hour interview about all my experience over the last few years, ma'am. So that is my next topic. I'll present it, ma'am. Any other questions, ma'am, I need to answer?
Any other comments from the chairpersons or the panelists, please?
I think it was an excellent paper and well documented. I know how hard it is to document 3,000 plus patients, that too over a period of time. And I'm sure you would see a pattern there. What do you think would be likelihood of testing it further in what lines, madam?
Yes, actually, that is what they also questioned me. That is to deeply dive into the ETO pathogenesis. In our government sector, just now, I've got with much support. For all young ACS, we need to see what is the exact etiology, how is the plaque morphology, and even we also need to assess some using OCT, or now we have the even with just the angiogram, incorporating artificial intelligence as to which plaque will suddenly rupture and cause acute MI. So that should be a line of workup so that we can treat them early, catch them early, and put them with the high dose drugs. But biovascular scaffold is, they say, if we are going to put in a biovascular scaffold, that is, we are going to treat almost 80 patients unnecessarily, we are going to stent them for one patient of acute rupture of the plaque. So at least we need to put them on high dose drugs. So we have to deeply dive into what is the pathogenesis going on. One is ectasias, as I've said, which now just on 1 second, I would like to comment here that while starting to ESE, one of my own assistant professors, I was very saddened by that. A young ACS, he suddenly collapsed. Another one was my young assistant's younger brother. He was my PG and assistant. His younger brother, who's a cardiothoracic surgeon, both within a period of 2 to 3 days, less than they were just around 30. One was 39, the other was just hardly 35. No comorbidities, no teetotalers who developed acute MI. They suddenly arrested before they reached the hospital, but all CPR, everything done. But in spite of it, everything primary, they couldn't recover both of them. It really saddened me because I am presenting a topic like this, and it has happened to two of my very close associates. So it was really saddening. So I wanted to, what I was feeling is, everybody, I think, will have ectatic coronaries. So when there is a slow flow, when we work hard, when we have, there is a slow, which is
Dr. Magella, your voice is breaking up. We can't hear. Dr. Magella, your voice has broken up. It's technical support. Can you hear Dr. Magella's voice?
No, ma'am, there's a network issue over there.
Yeah, Dr. Magella, I will request you to please fix your network issue because we can't hear you. And meanwhile, we do know that COVID has had multiple mechanisms of injury, the endothelial injury, there's hyperinflammation, there's a cytokine storm. We know that we're looking at also neutrophil extracellular traps, the nets and the platelet activation. But I can see that Dr. Priya Palimkar has raised her hand, and that will be the last comment for this presentation. Dr. Priya, please go ahead. Dr. Priya Palimkar?
Hello, can you hear me?
Yes, Dr. Priya, we can hear you.
Yeah, so I just wanted to ask is that was there any correlation studied between the vaccination of the patients? Because there has been a lot of hue and cry about whether COVID vaccination in itself caused an increase in the incidence of young MIs. And I think sometime back the internet was full with all of those kind of stories. So, for Dr. Cicely, I just wanted to know whether she had done any correlation like that. And of course, like Dr. Zakia said, that all COVID and of course, COVID, we know that it is a pro-thrombotic situation and people had all kinds of thrombus, right, from coronary strokes, pulmonary embolism, arterial thrombosis. So, how you want to deep dive into the cause. So I want to know also one more thing, that when you did the angiogram, did you think that it was an atherothrombotic thing or purely thrombus in the young MIs?
Dr. Magella, are you there?
No, ma'am, she's not here right now.
Okay, her connection timed out. So just contact her technical team and find out what is the issue. And Dr. Priya, your question was whether it's vaccine related. So there's not a lot of, consensus on that. And I believe that some COVID-19 vaccines, particularly the adenovirus vector vaccines, the ones which were from AstraZeneca and Johnson, have been linked to very rare and serious side effect called vaccine-induced immune thrombocytopenia, the VITT, which they were talking about. But still, the risk of thrombosis from the COVID-19 infection per se is significantly much higher than associated with any vaccine vaccine whatsoever.
Yes.
And I'm seeing another hand raised over here, but let me see. We have Dr. Vijayalakshmi's hand raised. So last comment from Dr. Vijayalakshmi, and we'll move to the next presentation, please. Dr. Vijayalakshmi, madam.
Yeah, I'm not able to connect. Can you hear me?
Yes, we can hear you, ma'am.
Yeah. This question is repeatedly asked during the TV interviews and all over. But whatever you said, in our country, the both vaccines that we have used, and absolutely there is no correlation between the increased heart attack and that. Because one is adenovirus. We know that adenovirus is a common cold virus, and that too, when it is attenuated, it cannot cause any reaction at all. And even ICMR has done in 4 studies, and they have shown that a vaccine is not a cause for the increased incidence of coronary artery disease. And the other one is, where the attenuated coronavirus itself is used. And since it is attenuated, naturally it will not be as harmful as the infection itself, as you mentioned, So I think the vaccine, that should be taken off our mind.
Absolutely. I fully agree that the risk is from the COVID-19 virus. It's not from the vaccine. So we need to be very clear that the problem is with the disease itself, not from the protective vaccine. That is just some rare episodes which we have seen of VITT, and it should not give the vaccines a bad name. So we'll go to our next presentation. If Dr. Majella is not here, she was going to present one more. If she's not here, we'll go to Dr. Asha Mahilmaran. Dr. Asha, you have joined. Dr. Asha Mahilmaran. Yes, I can see Dr. Asha Mahilmaran. Dr. Asha Mahilmaran is going to be speaking about an overview of late-breaking trials of ESC 2025.
Yeah, thank you, Dr. Sarita. I hope I'll try to share it. Can you see my slides now?
Yes, ma'am. We can see your slides. Can you click on enable
I'll
editing
just go
above?
to slide view.
No, you'll have to do enable editing first.
Okay.
Ma'am, please grant me the access I already requested to you.
Thank you, Dr. Sarita. I'll go on to an overview of late-breaking trials. So I was fortunate to be in person to listen to a lot of the late-breaking trials. So I thought I will get a quick grasp of overview of the major trials presented. There has been so many trials, it's impossible to highlight all of them, but the most important ones I will be trying to highlight. First was a podcast trial, which is a randomized study of superiority of potassium supplementation to maintain serum potassium between 4.5 to 5 in individuals who are already received an ICD. The primary endpoint was basically looking at death, arrhythmias, or heart failure hospitalization, ICD shock, or sustained ventricular tachycardia. It is a fairly large-scale study. About 1,200 were enrolled and 600 in each group. There were no safety events, and potassium supplement reduced the primary endpoint, and the number needed to treat was just 12.3. An increase of potassium by the level of 0.3 millimoles per liter resulted in a decrease in arrhythmia, ICD shocks, and this was something which highlighted the sweet spot of potassium level is probably between 4.5 to 5. But in this trial itself, they reached around 4.3 in most of the cases. 4.5 they did not receive in a majority of the cases. But even a small increase in potassium above the lower range was definitely beneficial. The highlight of this study was that the arrhythmias and other adverse events were much more at a lower hypokalemic level below 3.5. And above 5, it started increasing to a smaller extent, and the sweet spot was between 4.5 to 5. So going on to the next trial, the Odyssey HCM trial. It is about symptomatic non-obstructive HCM patients who were randomized to mavacamten versus placebo. Nearly 289 patients received mavacamten and 291 received placebo. Mavacamten did not decrease symptoms or peak VO2 in patients with non-obstructive HCM, and there was a greater reduction in EF and withdrawal in the mavacamten group. So it was a negative trial for non-obstructive HCM. We already know that mavacamten is approved in obstructive HCM based on the Valor HCM trial, but the Odyssey HCM trial did not show an extension of benefits to non-obstructive HCM. The MAPLE HCM is another HCM study which was done on obstructive HCM patients, aficamten 5 to 20 milligram versus metoprolol in symptomatic HCM patients. And there were 88 patients in each group. The minimal LVOT gradient had to be more than 40, and patients on aficamten had improvement in peak VO2, the symptomatic quality of life, NYHA class, NT-proBNP, and decrease in LVOT gradient and LA volume reduction. So this was a positive study for aficamten compared to the maximal dose of metoprolol tolerated in an individual patient. Coming to digit heart failure, this is a resurgence of digoxin and heart failure. The digit heart failure trial was a randomized placebo-controlled study that involved 1,240 patients with symptomatic heart failure and LVEF of 40% or less. The trial aimed to evaluate the efficacy and safety of digoxin who are receiving the current recommended guideline-mediated therapy for heart failure. The primary outcome showed that hospitalization or death occurred in 39.5% of patients on digoxin and 44.1% in the placebo group, resulting in a 4.6% absolute risk reduction and 18% relative risk reduction. Mortality and hospitalization was lower in the digoxin group compared to the placebo. Here, they adjusted based on the digoxin level between 0.5 to 0.9. And serious adverse events, when optimally titrated, were low, occurred in 4.7% of the digoxin group compared to 2.8 in the placebo group. So indicating a careful monitoring which is required in the digoxin group. Coming to beta blockers in post-MI with preserved LV ejection fraction was evaluated in the REBOOT trial. Predominantly, this trial was studied ejection fraction more than 40% post-MI, and 8,000 patients were randomized. And the mean participant age was 61 years, and 10% had experienced a previous MI. Beta blocker therapy did not show a benefit in this subgroup of patients with more than EF 40% in a post-MI scenario. And predominant use was bisoprolol. So they raised the doubt whether we have to routinely give beta blockers post-MI. So this is another trial looking at a similar population, beta AMI DAN block trial, looking at EF more than 40%, which led to a lower risk of death or major adverse cardiovascular events. The benefits were more in the lower range of EF, between 40 to 50%. And so the result was that it was a positive trial for beta blockers post-MI. Here, metoprolol was used. So a meta-analysis showed that patients post-MI with mildly reduced EF, but without heart failure, they benefited from beta blockers in similar way, less than 40%. But it is doubtful that patients above 50% are benefiting. And there was also a subtle suggestion that we need to move away from bisoprolol post-MI and go on to the non-selective beta blockers, which are proven like carvedilol or even propranolol in the age-old study. Coming to another trial on heart failure, the Victor trial, the Versigvat. We know that Versigvat is approved for recent worsening heart failure, but whether it was also beneficial in chronic heart failure was stable was analyzed in this large-scale study of more than 10,921 patients. And here, again, it was a negative study. The primary outcome was not beneficial in Versigvat group compared to that of placebo. So there was not much benefit in patients without any reason worsening. It did not decrease death or heart failure hospitalization. And going on to double choice trial, This is a TAVR-based trial where the local anesthesia is non-inferior to standard anesthesia, and both were found to be equivalent. And local anesthesia patients' tolerance was a little lower, but otherwise the outcomes, there was no difference. There were two valves which were tried out in this trial, Accurate Neo and Evolute. Accurate Neo almost had half the events as compared to Evolute at 30 days, showing that Accurate Neo valve was probably a better valve than Evolute based on this study. Coming to the Amalfi trial, the Amalfi trial was a 14-day remote monitoring which looked for atrial fibrillation in patients who are more than CHADS VASc 2, 3. And here it showed that the detection rates of AF and initiation of NOVAX were higher in patients who underwent 14-day remote monitoring, who were at higher risk for development of AF. So this was the Amalfi trial. Coming to TAXI trial, which is ticagrelor and aspirin or aspirin alone after coronary surgery for acute coronary syndrome. This compared a combination of ticagrelor with aspirin versus a ticagrelor alone in patients who are undergoing especially SVG grafts, and whether the graft patency and outcomes were better. It showed that there were more bleeding on the ticagrelor and aspirin group compared to that of aspirin, and there was not much benefit in the ticagrelor group. Again, the top CABG, this studied whether 12 months DAPT is beneficial compared to that of 3 months DAPT. And it showed that those in de-escalated group received ticagrelor twice daily plus aspirin once daily for 3 months, then placebo twice daily plus aspirin for 9 months. Overall, it was a non-inferiority study for the primary efficacy point of graft occlusion, which occurred in 10.7% of patients in de-escalated DAPT group and 11.9% in the DAPT group. And clinically relevant bleeding was less frequent in the de-escalated DAPT versus DAPT continued. So no differences in secondary outcomes were observed. So it was beneficial to have a de-escalation strategy, offers a better balance between graft patency protection rather than continuing DAPT with ticagrelor aspirin for 12 months. The DAPT shock AMI trial compared IV cangrelor versus crushed ticagrelor in acute MI and cardiogenic shock, and it showed that the outcomes were better in IV cangrelor as compared to crushed ticagrelor. The platelet reactivity index was much lower in cangrelor group compared to that with ticagrelor. It was 100% in cangrelor, whereas only 22.1% with ticagrelor. But the primary clinical endpoint, there was not met at 30 days. But there was a superior platelet inhibition in the initial time with IV cangrelor. The BAX hypertension trial was tried on the newer drug baxdrostat 1 milligram or 2 milligram to background antihypertensive therapy. And it was shown that the longer term safety is ongoing. However, in the first 12 weeks, serious adverse events were reported in 1.9% of baxdrostat group and 3.4% in 2 milligram and 2.7% in the placebo group. Hyperkalemia was a problem in about 0.8% of patients who were taking baxdrostat and 1.5% taking baxdrostat 2 milligram. So this is a trial with caution. Cardia 3 was on the zilebesiran single subcutaneous dose compared to led to a 5 millimeter reduction in systolic blood pressure in 3 months compared with placebo. However, the difference did not reach statistical significance. So the excitement about zilebesiran has not been proven in the Cardia 3 trial. It is not more beneficial than placebo was the conclusion. Coming to Dan Canvas 2 trial, the incidence of death among men 60 to 64 years compared with men who did not undergo comprehensive cardiovascular checkup. Whether cardiovascular checkup using CT calcium score was more beneficial was what was analyzed. That an important observation was increase in bleeding was seen in the invited group because they were more likely to receive higher aspirin intake, and thereby there's some caution that using the CT calcium score for universal screening is to be advocated with more caution as with the recommendation based on the Dan Cavas 2 trial. The alone AF trial. So if patient do not have any other comorbidities, only atrial fibrillation, whether you can discontinue whether you can discontinue after ablation was studied in this Korean study, and it was shown that it discontinuing was not was associated with decreased bleeding, and there was no difference in ischemic events. So it may be quite safe to discontinue after catheter ablation for AFib in patients who do not have a high CHADS VAS2 score. So this was what was discussed in the study. So I think I've given an overview of a few of the trials which were presented. So we can have more discussion on any of the trials.
Thank you, Dr. Asha, for that amazing presentation. It's a great overview of all of the trials which were presented over there. Very interesting outcomes from many of them. The House is now open for comments by the chairpersons and the panelists. Some comments, please. Dr. Sujata, Dr. Jyotsna ma'am, Dr. Zakia, Dr. Madhu, Dr. Priya. I think all of the topics presented are very interesting. And again, the role of digital is coming back aggressively, and very interesting results with mavacamten and efacamten. So overall, very interesting, and the role of reduced DAPT in our post-CABG patients, the role of potassium supplementation in reducing the mortality in our post-ICD page. Very interesting results, all of it. Some of them already known, proved, and some of them coming back in some new data. Very interesting. So thank you, Dr. Asha. We'll move to our next topic, and that is by Dr. Prachi Sharma. Dr. Prachi Sharma is going to be presenting incidence and outcomes of critically ill obstetric patients with heart diseases. Dr. Prachi, please share your screen.
Prachi has to unmute herself.
Hi, ma'am. I'll just share my screen. 1 second.
Yes, we can see your screen.
Okay.
Can you go slideshow?
Is that fine, ma'am?
Yes, perfect.
So, okay, thank you so much, ma'am, for organizing this meeting here so that we can exchange our ideas. Good evening, everyone. So this is what I presented there at the ESC this year, and it is our study on the incidence and outcomes of critically ill obstetric patients with heart diseases. So what we did was an observational study over 1 year, and we studied what were the etiologies and outcomes of all those critically ill obstetric patients who had some cardiac problem associated with them and were admitted to our ICU. So we know that cardiac diseases are a major contributor to maternal morbidity and mortality. So we did this observational study, and we included both primary cardiac etiologies and pregnancy-related cardiac involvement. So over that 1 year, we had almost 62 critically ill patients getting admitted to an ICU. And the two most common cardiac etiologies were peripartum cardiomyopathy in almost 56% of the patients, and pre-existing rheumatic heart disease in more than 30% of the patients. So the most important thing to note here is that only less than 10% of the patients were primigravida. Majority of them had had a previous pregnancy, and still pre-existing rheumatic heart disease was undiagnosed, which was there in more than 30% of the patients. So that was one interesting and disheartening point about what we found in our study. Another thing that I want to mention here is that majority of the patients were diagnosed in the peripartum period. So there were only 4 patients who knew about their cardiac illness before the start of their pregnancy. 4 of them knew about their cardiac problem, and the rest of them, only 2 could be diagnosed during routine antenatal examination. So apart from those 6, all of them were diagnosed when they landed up in ICU, got critically ill. So that is the unfortunate scenario which we wanted to highlight, and that is the social problem which we are facing. So only 4 were diagnosed earlier, and out of them, 2 had undergone BMV earlier, and 1 had undergone mitral valve replacement earlier. So they were taking treatment, and the 4th one was also rheumatic heart disease. And despite being multigravida, and they landed up in pulmonary edema, almost half of them. They landed up in sepsis, almost 20%, and 72% required mechanical ventilation, and 14% had cardiogenic shock. And if we calculated their SOFA score, as we in the critical care team does in the critical care ICU, that is the sequential organ failure assessment score, that was high. 3.4 means it is 0 to 4, so it is towards the higher side. And the Carprig score was also high, and that was significantly related to the maternal mortality. Now we looked at the obstetric, fetal, and the maternal outcomes. If we look at the obstetric outcomes, 62% had to undergo an emergency cesarean section, because majority of them landed up in pulmonary edema, they were ventilated, they were in cardiogenic shock, so they had to undergo emergency cesarean section. And when was that? That was around 32 to 33 weeks. If you look at the mean age of delivery, just mean age at gestation, that was almost 32 to 33 weeks. So they were preterm babies, majority of them, and that is why if you look at the fetal outcomes, there was almost 35% intrauterine death, and many of them landed up in ICU. So live healthy babies were almost 30%, who did not require ICU, and rest of them either had like stillbirth, neonatal death, or did require an ICU support and were discharged in a healthy way. And maternal mortality, that is the third thing we looked at, that was also high. That was to the tune of 21%. So that was very high maternal mortality in this subgroup of patients. So what was important was, and what we realized was that obviously there is significant morbidity and mortality associated with the heart diseases during pregnancy and the peripartum period. But most important is early diagnosis and management through routine cardiac examination during antenatal visits, because majority of them were diagnosed only when they landed up in ICU, when they got critically ill during that 32 weeks when they faced the hemodynamic stress of pregnancy. And during routine antenatal examination, they were not picked up. So we require better interdisciplinary management and pre-pregnancy counseling, which can like save these patients from landing up in ICU and dying. Thank you so much.
Thank you, Dr. Prachi. This is a very interesting study, and thank you so much for presenting it. It's actually brings to light the situation which is still prevalent in many parts of India, and the fact that it was diagnosed so little and so few patients got to know before they were pregnant, that they had these cardiac issues, and the fact that there's a high maternal mortality and a high IUD is really sad, which means that we need to do an early diagnosis in our ladies. And that screening, the importance of screening for this, the importance of women also going in for a cardiac checkup is so very important. And if every woman just had a simple ECG and an echo, a lot of this could have been picked up, and a lot of that maternal mortality and the fetal mortality which occurred could have come down. So it's a great presentation. The House is now open for comments and questions from the chairpersons and the panelists. Please go ahead.
Nice study, Doctor.
Hi, ma'am.
I think a lot of tertiary areas, areas where access to healthcare for pregnant women is still a big issue. A lot of healthcare workers, at least in Maharashtra, we have this Anganwadi concept. So a lot of Anganwadi workers do pick up these problems and get them. Their treatment is escalated. At the same time, in urban areas, what we see now is that infertility is on the rise, and what you see is more of precious babies, which are born because of IVF or some sort of medical help. And then you have complicated pregnancies that are associated with hypertension, gestational diabetes, and all that. So I think India is a country where you see both extremes of problems. And we are hoping that problems at the level of villages and where the healthcare is still an issue are better taken care of. Thank you.
Right, ma'am. I think we cannot generalize these statistics because it is a tertiary care referral center. So the worst of the cases are referred there.
Right.
The statistics cannot be generalized, but yes, the problem is there. That is what we tried to know.
Can I make a point?
Yeah, sure, ma'am.
Yeah, Prachi, that was a great presentation.
Thank you.
Congratulations.
Thank you, ma'am.
I remember the olden days. As you mentioned, the rheumatic fever is the commonest. We had one lady full-time pregnant. She came with the pulmonary apoplexy, almost coughing out half a liter blood every day. 0.4 square centimeter was the pinpoint mitral stenosis. We did it in the not fluoroscopy, with the echo-guided balloon dilatation. And the same evening she delivered, had a normal delivery. Otherwise, she would have definitely died. And another patient who presented with convulsions and they were referred, and that happened to be peripartum cardiomyopathy, huge LA and LV thrombus. They're almost like a ball valve, and because the thrombus was disintegrating with every beat and then shower of embolism and came with the convulsions. And that patient we could not save. And the third one was, the spontaneous dissection of the coronary artery. And those days we didn't have the stent like that we have today. Maybe if we had the stent like that, we could have saved that lady. And that is another thing. And one more lady, full-term pregnant, and she had a dissection of aorta. And of course, we could somehow manage, and it is really difficult because these are the commonest conditions where make the pregnant lady prone for the catastrophe. And your study is very good. Congratulations.
Thank you, ma'am. I think another point is we could have a comparative arm where we could diagnose these patients during pregnancy and we treated them. So what were the outcomes when they were actually treated? So because these were the patients who were in the ICU and they were not treated. So definitely we have more patients who are diagnosed also and who are treated also during pregnancy. And they do well. They do not land up in ICUs during delivery.
Dr. Prachi, there is a question for you in the chat box from Dr.
Yes, ma'am.
Anil Kumar Mahapatro. So he has asked, did you include peripartum cardiomyopathy patients who were diagnosed before delivery?
Yes. As I mentioned there in the etiologies, half of them were actually peripartum cardiomyopathy.
A very interesting study, Dr. Prachi. I
Thank you.
think I think Madras, the study also 1/3 of patients only were diagnosed antenatal. 78% came without knowledge of their pre-existing cardiac condition. And obstetricians with their busy practice are unable to diagnose heart disease with conviction. So I think just like universal ultrasound screening, we need to recommend echo screening 3 months and 7 months antenatal. that will go because 21% antenatal mortality seems to be extremely unacceptable.
Yes, yes. Right, ma'am.
And
Because
the shift
if
is more towards peripartum cardiomyopathy rather than rheumatic heart disease today. So I think we need to definitely have 2 ultrasound screening, one in the first trimester and one in the last trimester. That should become the recommendation. Probably we should come out from Wincars.
true, true.
Absolutely. I
Dr.
think the
Prachi,
pregnancy
yeah,
guidelines.
that was a great presentation. Yeah,
Hello.
it was superb. Yeah, it was really great. And I was also stunned by the maternal mortality and IUD. It was quite alarming. I think we from Wincars, we should bring in a protocol to bring down, as mentioned by rightly by Dr. Ashaman. And one thing I would also try to recommend is instead of after pregnancy, I think we have to catch the teenagers, have a screening echo. It's just 1 minute. We can just screen them and rule out all teenagers. I think that will prevent them even before marriage. We prepare them well in the teenage adolescent screening. Around 18 years for all female patients should bring in mandatory echo and ECG and a cardiac evaluation, so that I think we can definitely bring down, because after diagnosing them during pregnancy, it's very difficult to manage. To do a PTMC, as Madam said, it's really tough after the 32 weeks. The cardiac output is too high to intervene in such patients. It's really tough, and especially in twin pregnancies and all, it's very tough. We might lose the patient on the table during any interventions. So we have to do it, screening at the teenage, pick them up early and treat them. That would be the right way to go. And for peripartum cardiomyopathy, as IB ma'am told, the thrombotic, I've done a study in a large sector of patients with peripartum cardiomyopathy. The thrombotic and EF in a normal individual with the 40% or 35% in pregnancy, the same EF, they tend to develop thrombus high. The thrombotic burden is high. I had presented in previous World Congress of Cardiology that the thrombotic burden in peripartum cardiomyopathy, generally the pregnancy itself is a prothrombotic state. So even with a EF of 40, so the role of anticoagulants in peripartum cardiomyopathy, even with an ejection fraction of 40%, is very essential in such patients.
Right.
Thank you, Dr. Majella. Very nice
you, ma'am.
comments, and we need to look for more screening, especially in our women. We agree with that. And but like Dr. Prachi said, this is a tertiary care center where all sick patients are referred, so may not be a true representation of our entire population, but definitely women need to get screened, so that, because there are 2 lives at risk over there that we are looking at. We have a last question we'll take. Dr. Neelam Kaul has joined us, and she's asked you, Dr. Prachi, that is there a role of NT-proBNP to detect peripartum cardiomyopathy early?
Yes, definitely. Why no? Because echo may not be readily available everywhere, and it may, I mean, to all the patients. So maybe if you are not able to do echo for every patient, but maybe if we look at the minor symptoms, early symptoms, and the obstetrician may be educated about that. If they are like suspicious about the minor symptoms, they can first go for NT-proBNP as a screening, and if need be, then they can go for echo, because echo may not be everywhere that readily available.
True. So a blood test would be simpler to get it done than an echo. That point carries validity, and yes, early things can be picked up on that. So we have already crossed the time. Dr. Prachi, thank you for that amazing presentation. I would like to thank all the chairpersons, all the panelists, and all our 3 amazing speakers who represented Wincars so well at the ESC. Thank you so much for an excellent evening of academic discussion, great contributions, learnings, and inspirations for what we can do in the future for the women of India. Thank you so much. Good night and have a great weekend.
Good night. Bye.